Okay, so this will be part 3 of our childhood growth and development questions. We have a 2.5-year-old child presenting with his mother for swollen ankle after having fallen down 2 steps this morning. Mother is visibly concerned. There are no other injuries. Physical exam reveals erythema on the right ankle. Range of motion limited by pain. Birth history was unremarkable, and he was born term at 7 pounds 8 ounces with no postnatal complications. AP and lateral x-ray of the ankle are ordered and reveal some soft tissue swelling but no bony abnormalities. Which of the following weights would be most appropriate for this child? A, 22 pounds, B, 25 pounds, C, 27 pounds, D, 30 pounds, or E, 35 pounds. Okay, so with this question, I wanted to point a few things out besides just the answer to this question. So let's go on to the answer here. You should pause it if you haven't gotten to the answer yet. You're probably doing a little bit of math right now. Okay, answer is D, 30 pounds. So anytime you read a question on the USMLE, just a piece of general advice, and I tell this to my Kaplan students all the time, is that you should read the question stem at the end first, because that's going to help you when you're looking at the vignette. And indeed, in this question, we have a bunch of information that's given out that's really not important for answering this question. So everything about the ankle really doesn't matter, because what we're asking is what's the appropriate weight for this 2.5-year-old child. And remember that at birth we have a weight, and then at 4 months old that weight should double. By 1-year-old that should triple, and by 2.5 years old it should quadruple. So this child is 2.5 years old, so their weight should quadruple. Just multiply 7 pounds 8 ounces, which is 7.5 pounds, by 4, and you will come up with 30 pounds. Now, if the child's 27 pounds, or if they're 35 pounds, we might consider that to be okay, but it's not ideal. The question here is asking you what's the ideal weight for this child, and that would be 30 pounds. You would be exactly quadrupling their birth weight at 2.5 years. Certainly 22 or 25 pounds, we would consider that to be probably abnormal, and maybe look into some things, such as eating behaviors and stuff like that. Other things I wanted to point out here is that you have some soft tissue swelling and an injury from at the ankle. So the mother is visibly concerned. That's always important. Anytime you have a parent that's not very visibly concerned, and you have issues like a falling down steps or something like that, you want to always consider neglect. Typically, that's not what's going on, and when a parent is very visibly concerned, panicking, that's generally not consistent with neglect. And then other things that I wanted to point out is the AP and lateral x-ray that you're ordering. You always want to get at least 2 views anytime you're considering an orthopedic injury. Okay, question 12. A 16-year-old girl presents to your clinic complaining of persistent headache, occasionally accompanied by vomiting over the past 6 months. She denies any other symptoms and had been relatively healthy until these problems. She recently saw a colleague who diagnosed her with migraine and supplied her with topiramate and sumatriptan, which she says has not helped. You notice on her medication list that she is taking a multivitamin and isotretinoin for acne. Physical exam reveals cheilitis. CBC is unremarkable. CMP is significant for a calcium of 11.4. CT of the head is unremarkable. Which of the following is most likely the diagnosis? A, hypercalcemia from multivitamin use. B, hypervitaminosis A from multivitamin use. C, hypervitaminosis D from multivitamin use. D, medication adverse effect. Or E, tension headache. Okay, answer here is medication adverse effect. So this is a classic presentation of hypervitaminosis A. Why? Well, we have the typical symptoms. So persistent headache. This is going to be an elevated intracranial pressure, and that's a symptom of hypervitaminosis A. We also see that the patient is taking a multivitamin. That's good. But they're also on isotretinoin. And one of the adverse effects of isotretinoin is vitamin A toxicity, because this is really just a lot of vitamin A that you're giving the patient. And this is good for acne, and most patients are fine on this, but there are some patients who will develop the adverse effect of hypervitaminosis A and have some symptoms of it. So the mild cheilitis is also a symptom of vitamin A toxicity, and certainly these headaches with vomiting. Now, the differential, certainly for headaches with vomiting, is going to be migraine. So the child is on topiramate and sumatriptan, and that has not helped. And so remember that topiramate is Topamax, that's given to prevent migraines, and sumatriptan is given to abort migraines, and that has not helped. So this is probably not migraines. Also, this is a persistent headache. Migraines are typically episodic. So the answer here is an adverse effect, probably from the isotretinoin. In this patient, you're going to want to discontinue the isotretinoin and start the patient on something else for the acne. So maybe an antibiotic. You could also do something like DUAC ointment, which is benzoyl peroxide and clindamycin. That would be good, but you definitely want to get this patient off isotretinoin. So this is due to an excess of vitamin A ingestion for several weeks or months. The signs include the nonspecific signs like headache, irritability, vomiting, diplopia, hepatomegaly, splenomegaly. So we saw the headache in this patient, the vomiting, possibly irritability, we don't know necessarily. More specific, you'll see increased intracranial pressure, bulging fontanelles. Of course, that's not going to be seen in this patient because presumably the fontanelles are closed by however old this patient was, 16 years of age. Desquamating rash on the palms and soles may be present, cheilitis, and hyperostosis. So remember these ones in bold. These are the more important ones. The cause is excessive use of supplements such as vitamin A tablets or cod liver oil. Dietary issues. Liver is very high in vitamin A, so usually a lot of kids don't like to eat liver. Sort of the classic thing in the US that's really disgusting food is liver and onions, but some people like that. And then use of certain medications, especially isotretinoin. Remember, when we're dealing with teenagers, they tend to have acne, and so this is one of the medications that's given for acne. The symptoms will rapidly resolve with withdrawal of the vitamin or the source, and your workup will include a CBC. You'll get chemistries, liver function tests, because you can get some hepatic issues, and vitamin A labs may be obtained, but typically this is something that's very easy to diagnose, especially if they're on isotretinoin or they're taking excessive supplements. Vitamin A is not something that's very easy to get a lot of, so usually there's something medically that the person is taking, like a medication or vitamin supplements, or something very unusual in their diet, like liver. Question 13. A 3-year-old girl presents with her mother and family friend who is acting as an interpreter, as they are recent immigrants from rural Mexico. The mother describes that her daughter has been tired and listless over the past few months. There's no significant past medical history or family history, not of, or. Review of systems include a mild diarrhea. On physical exam, you note a shy girl who prefers to sit in her mother's lap. There is redness confluent on the face, shoulders, hands, and feet, which the mother describes as a sunburn, which she seems to have a predilection to. You note some blisters along the arms. CBC and CMP are within normal limits. Which of the following is the most likely cause of this patient's symptoms? A, inadequate vegetable intake, B, wheat-based diet, C, corn-based diet, D, parasitic infection and malabsorption, or E, inflammatory bowel disease. Remember now on the USMLE and on a lot of standardized tests, there's often more than one possibility, but the question is asking the most likely cause. So if you can get rid of all the wrong answers that are certainly wrong, and then go down your list of possibilities, choose the one that's most common. All right, the answer here is C, a corn-based diet. Now this is sort of a difficult question for a few reasons. One of the things that helps is sort of an idea of what different populations eat. And in Central America and South America, they tend to have very much corn-based diets. And corn is very low in certain nutrients. And in this case, that nutrient is niacin. Now, there are some other possibilities. Inadequate vegetable intake, probably not. You tend to have niacin in a lot of different vegetables, and we don't necessarily have inadequate vegetable intake as part of this problem. There's probably we don't see any real abnormalities in the patient's diet. And if you ask mom if she's a picky eater, she'll probably say no. Wheat-based diet, that's not going to cause a niacin deficiency. Parasitic infection and malabsorption, that is possible. A parasitic infection is possible. That can certainly cause a mild diarrhea, but that's not going to explain this redness on the face and the shoulders, hands, and feet that looks like a sunburn. It's also not going to explain blisters, and typically with a parasitic infection and malabsorption, it's going to give you weight loss. It's also going to likely screw up your CBC. You can have some abnormalities in your white count. And then inflammatory bowel disease, that can also cause diarrhea, but typically you're going to see blood loss too. And so, like I said, that can screw up your CBC. This is most likely niacin deficiency, and a niacin deficiency will often come from a corn-based diet. So with Pellagra, you're going to look for certain things, and they pretty much all start with D, which is useful. So dermatitis, it typically looks like a sunburn. You can get blisters that develop. Usually it's seen in a cape-like distribution. So you'll have a symmetric appearance. A lot of times this will be accompanied by stomatitis and glossitis. Diarrhea can alternate with constipation. You can have depression. That's difficult to diagnose in young children, though. Delirium can include hallucinations, especially olfactory, unevoked sensations of pain. Dementia, again, this is difficult to diagnose in children, but a lot of times it's going to be that listlessness. Rather than dementia, you could think of maybe altered mental status in children. So things like restlessness and agitation. Dilated cardiomyopathy, this isn't tremendously common, but it may be there, so it might be something to work up, but we don't likely have a dilated cardiomyopathy in this child because we don't see any signs consistent with that, and then death if not treated. So vitamin B2, vitamin B3, I screwed this up here. Okay, vitamin B3, which is niacin, will be found particularly in meats. There are certain vegetables that you can find it in, such as peas, seeds, avocado, but if you don't get a lot of meat in the diet, you can be at risk for niacin deficiency. Then also remember the corn-based diet can cause a niacin deficiency. Okay, question 14. A mother presents with her 15-year-old son. Last week she caught him naked in bed with another boy. She is very distressed and says he normally has had girlfriends in the past and has never expressed interest in boys. The son says this was the only time he has ever done this, but he is unsure about his sexuality. Which of the following is the most appropriate response for this mother and son? A, we need to perform immediate testing for STDs. B, sexual experimentation is common at this age, but he should know his sexual orientation. C, your son was likely sexually abused as a child. D, sexual experimentation is common at this age. E, your son is probably bisexual. You're going to get a lot of questions like this, which asks you to what to say. And that's going to test not only your ability to be a doctor and say the appropriate things, but also your knowledge of what's going on. Okay, so the answer to this question is D. Sexual experimentation is common at this age, and it really is. 15 years old, you've got, especially with boys, they're right in the midst of puberty, and so they're really discovering their sexuality. So here you have a mother that's obviously distressed because this is not something that's really normal. I mean, it's normal. It's not common. So you don't see this in most teenage boys, but it is normal. And sexual experimentation is common. And so what you don't have, though, in a 15-year-old is typically a sexual identity. Now, if you ask the child, they may tell you, I believe I'm heterosexual, I believe I'm homosexual, I believe I'm bisexual. But a lot of kids at this age won't really know, and they're really just discovering this. The kid does not know their sexual orientation, and more importantly, sexual orientation is not a diagnosis. So we're not concerned about determining what the sexual orientation is of this child. He will discover it on his own and come to the conclusion, and we just respect that. So as far as performing immediate testing for STDs, that's not of the utmost concern right now. So I would do it, I would recommend it, but that's not going to be the first thing you say to this mother and son. That's not going to be your first response. So what you will do is you're going to ask, was there any sexual activity? We don't know that just based on this history. All there was nakedness, so we don't know if there was any sexual activity going on. If you do ascertain that that is true, then certainly you can go forth with testing for STDs. But we don't know that yet. As far as sexual experimentation being common at this age, that is true, but most kids of this age don't know definitively their sexual orientation. Your son was likely sexually abused as a child. That is a very common myth about homosexuality. Most people who are homosexual or bisexual were not sexually abused, and so that is a wrong answer for sure. And then your son is probably bisexual. Again, we do not diagnose patients with their sexual orientation. We state their sexual orientation based on what they report to us. Now, we can make a diagnosis, note on the chart that the patient is a male who sleeps with both genders or sleeps with one gender or is attracted to both or attracted to one. We can note that because that's going to be important as far as men who sleep with men. We want to make sure we're testing them for HIV because they're a population that's specifically at risk. But we don't diagnose, we don't tell a person what their sexual orientation is. That's always wrong. So just say that sexual experimentation is common at this age. Then you can go ahead and ask other questions, again, preferably with a mother outside of the room, considering that this is an adolescent who can answer his own questions. Likely he's not going to want to talk around his mother since she's distressed, and probably, that's fine for the mother, but you want to talk to this child one-on-one. Okay, so some things about sexual identity in adolescence. Sexual orientation is not a diagnosis, as I mentioned, and it's not your job to discover what the orientation is. Rather, you want to create an environment where the adolescent can discuss any questions or worries that they have. You do want to ask whether they identify themselves with a particular sexual orientation, because the child may not want to say in front of their parents. And then you want to ask if they're confused or anything like that, because those can be risk factors for depression and anxiety and stuff. But you're not diagnosing a patient with sexual orientation. Throughout adolescence, most youth are going to question their sexual orientation one way or another, and certainly this can be confusing because it is quite possible to be emotionally attracted to one gender, physically attracted to another, or you can get this thing where youth will very much admire somebody, like maybe a gym teacher or a teacher, an adult figure, maybe who's of the same sex, and it's really just admiration, but then they get this idea that, well, what's wrong with me? And especially, kids can get bullied and be told they're gay or a faggot or something really derogatory like that in the case of bullying, and that can be really confusing. So you want to try to ascertain if that is there. And so this all leads to that confusion that can be really distressing for kids. And so it is considered very normal because of all of this for youth to feel somewhat uncertain or ambivalent about their sexual orientation. This will go away once they're towards the end of adolescence. They typically will have their sexual orientation kind of locked down. Okay, question 15. You are working in a remote village in sub-Saharan Africa when you encounter a 2-year-old boy. He's been breastfeeding until approximately 3 months ago when his younger sister was born. For the past 2 weeks, according to his mother, he's been sleeping more and has been irritable. His diet presently consists of corn, bananas, and bread. On physical exam, you note generalized edema, fluid wave, and mild hepatomegaly. Metabolic profile reveals sodium 137, potassium of 4.9, bicarb of 24, chloride of 101, BUN of 14, creatinine of 1.1, glucose 85, calcium 8.1, magnesium 1.0, phosphate of 2.7, and a TSH of 1.9. A total protein is 5.1. CBC reveals a microcytic anemia. Which of the following steps are most appropriate at this time? A, small and frequent feeds, 80 to 100 kilocalories per day. B, feeding is tolerated. C, iron replacement. D, hospital admission. E, B12 and folate administration. F, frequent electrolyte checks. G, stool studies. H, magnesium replacement. I, penicillin and metronidazole. J, hydrochlorothiazide. And K, PO fluids. Which of these are you going to do? And of course, there's more than one answer here. Okay, answers here are, go ahead and pause it. Okay, answers are A, D, F, G, H, and K. Now, are we going to do other things possibly? Yes, but this is going to be all part of your initial steps, and then based on this, then we can do more. So small and frequent feeds are going to be what we do for patients that are in. Okay, so let's go back. What does this patient have? So we note that the child's diet is corn, bananas, bread. None of this stuff has protein in it, so that's important. Plus you have generalized edema. That points towards protein deficiency. And the fact that this kid was breastfeeding. Breast milk has a large amount of protein. That's good. But then 3 months ago, younger sister was born, and so the mother probably stopped breastfeeding the child and started breastfeeding the younger sister, and now the child is protein deficient. And we see that with the generalized edema, the diet, the fluid wave, and the hepatomegaly. We also see it on labs, and these are all pointing towards sort of generalized undernutrition, not necessarily just protein deficiency. We see a low calcium, a low magnesium, a low phosphate, and a low total protein. So what do you want to do when you have a child that is protein energy deficient? You want to have the child on, of course, on some kind of nutritional replacement. So you'll do small and frequent feeds. And the reason you do small frequent feeds is that you don't want to get overfeeding syndrome. And overfeeding syndrome is a very big problem, and what happens is that the cells pull in as much phosphate as they can to make ATP, and what that's going to do is lead to a profound hypophosphatemia, and that can be deadly. So we want to gradually reintroduce the food, and you'll start small, frequent feeds, 80 to 100 kilocalories per day. So not feeding is tolerated. You also want to do a hospital admission. These patients need to be watched. Another thing we're concerned about anytime we have an issue with protein energy malnutrition, because there is that possibility of refeeding syndrome, is that you can get metabolic abnormalities. So you want to do frequent electrolyte checks. You can do stool studies to see if there's any other problems here. Then magnesium replacement is always going to be important. Anytime you have hypomagnesemia, you can get abnormalities in other electrolytes. So we want to replace the magnesium. And then PO fluids is going to be important too. You don't need to do IV fluids because this child, one, is not having profound diarrhea, so there's no absorption issue that you might get from dysentery or cholera. So you can do PO fluids because the child otherwise is pretty healthy, other than the fact that they're not getting enough food and protein and stuff. So I already said why you don't need to do feeding is tolerated. Iron replacement you don't necessarily have to do because with the refeeding, the child will get that necessary iron. And we really don't have a profound issue with anemia. B12 and folate administration is probably not necessary because you have, this is only an acute problem. So this has only been going on it's only been 3 months since the child stopped breastfeeding. And we know that the child is getting fruit and vegetables. So that is probably going to say that there's no folate issue. And then B12, you generally have stores of B12 for quite a while. And then also, with B12 and folate issues, there tends to be a macrocytic anemia. So there's no signs that there's a B12 or folate issue here. Penicillin and metronidazole would be an appropriate treatment if the child had NOMA. And NOMA is something you can see in protein energy malnutrition. It's an infection around the mouth. And that you would treat with penicillin and metronidazole, but that's not present in this patient. Hydrochlorothiazide would be a great treatment if this generalized edema was due to a cardiogenic problem, but this is not. This is due to an oncotic pressure issue because the child does not have enough protein in their bloodstream, which pushes the fluid out into the subcutaneous tissue, and that's what's leading to the edema. So we do not do hydrochlorothiazide here. That would be absolutely the wrong thing to do. So our initial approach to protein energy malnutrition, it's pretty easy to diagnose clinically based on the history and also based on the physical presentation. You want to do a CBC looking for anemia due to iron deficiency, folate B12 deficiency. We have a microcytic anemia, likely pointing towards an iron deficiency, not a folate B12 deficiency. We also know this probably isn't a folate B12 deficiency because this has only been going on for a short period of time and we don't have a macrocytic anemia. We also want to get, and also if you have an iron deficiency, you can go on to get iron studies, but that's not necessary in this case. BMP, you should get plus calcium, magnesium, phosphate levels. You want to know all your electrolyte levels because we're going to be looking for electrolyte disturbances, particularly in the near term in these patients. We want to look for an iodine deficiency because this patient already has a malnutrition problem. Anytime you have a malnutrition problem, you want to check for other possibilities surrounding malnutrition. So iodine deficiency is a big one, particularly when you're practicing in and usually the USMLE won't ask you a question like this because we're concerned about the United States. But if you're working in sub-Saharan Africa, yes, you are concerned about iodine deficiency in many cases. Total protein, usually this is going to be low, but you definitely want to get this anytime you're concerned about protein energy malnutrition, obviously. Stool studies, you can look for GI infections, and then other labs as indicated by individual patient status. So the stool studies, if you didn't choose that, it's probably you can get away with that, but I would do it. Just because whenever you have malnutrition, you want to make sure that it's not due to some kind of infection or something. Okay, so the management of protein energy malnutrition is phased, and that's to prevent refeeding syndrome. So if just as a sort of medical history piece of trivia, back when in the 1940s when the armies came in and they were treating people in the Holocaust, the Jews that were malnourished, a lot of these patients, they just ate everything they could when they had the opportunity. And what did that do? That provided them with a ton of phosphate. Their cells pulled it in to make ATP, and that caused a profound hypophosphatemia, and that is deadly. So you want to do a phased reintroduction of food. If possible, this should be advised by a specialist. So your management first is going to include stabilization. You want to correct any dehydration, preferably with PO fluids, but IV fluids, if they are necessary, you want to check their hydration status regularly. You'll begin feeding. There are different products that are good for refeeding. You're typically not going to just give food because you want to have the patient on something very specialized for for protein energy malnutrition, something that's got very specific amounts of the different electrolytes and nutrients, so that they're not going to go into some kind of metabolic disturbance. They're not getting more sodium than they are potassium. So these are all very specialized for protein energy malnutrition patients. So there's F75 or RUTF that can be given, and that's 80 to 100 kilocalories per kilogram per day. I don't think I put that on here. Yeah, kilocalorie per kilogram per day, not 80 to 100 kilocalories per day. Oops. So kilocalorie per kilogram per day. I kind of rushed through that here. So yeah, certainly kilocalorie per kilogram per day. So if you have a 20 kilogram patient, you'll give them 1,600 to 2,000 kilocalories per kilogram per day. You'll want to start with smaller and more frequent feeds, of course, to prevent refeeding syndrome, and then phase the patient up to larger and less frequent feeds. You want to give antibiotics for any suspected infection, and then frequent electrolyte checks, and you'll carefully correct any imbalances. After the first week, you move into rehabilitation. You can increase the number of calories, and what we're doing is we're increasing the number of calories to bring the patient back up to a normal weight. And so for this, you can use F100 or the RUTF, and you'll be at 100 or possibly more kilocalories per kilogram per day. And then at this point, you can start iron replacement if you need to. But a lot of times, there is iron in these refeeding products, so the anemia may remit from that. But if it doesn't, you can do iron replacement at that point. You'll discharge the patient after 6 weeks, recheck them, continue the feeding protocol until they catch up and grow.